Well, this song is dedicated to the children of Africa. We're here to say that no child should be born with HIV in Africa. And if you believe with me, rise on your feet and let's sing together. Yo, 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 yo. About the children infected with HIV. Some are orphaned and they don't know what to do. Who will fight for the rights? Who will really care about them? That's why we sing Pata. We care for the children. Whoa, whoa. Whoa, yeah, 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 yeah. Yeah, 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 yeah. Africa will see, Kenya will shout, Tanzania, Mali, Ivory Coast, South Africa, Swaziland, Lesotho, Malawi.
Our request of you is, as you're listening to the cases, as you're listening to the experts speak, think about questions that you have. And then there are two ways for you to ask your questions. The one way is that you raise your hand, which is one of the functions on Zoom, which means that when it comes to the Q&A time, we will invite you to ask your question. The other option is that you just type your question into the chat, which you should also see on the Zoom function. And then Agnes or I will ask your question for you at the end. We just also want to say there are no silly questions at all. For every question that you have that pops up in your mind, there's 100 other providers that have exactly the same question. So as Agnes said, today is about being real, and yeah, we don't have to stand on ceremony with each other. And then finally, I think it was mentioned on the video, but we just wanted to explain that there are going to be a series of real sessions. And if you participate in 4 real sessions, then you receive a certificate of participation. And the only way that we can do that is if you register. So you'll see that Glynis Gosman from PATA has put a link in the chat. So if you want to register your attendance, then click that link. It will ask you a question or two, your name, where you're from, and then your attendance is registered, and you do that 4 times, and then we send you a certificate. So enough talking from me. I'm stopping, and I'm so excited to be handing over to Maxwell. So there's a little bit of sound interference. There we go. Maxwell, brilliant. Handing over to you. We're so excited to hear your case. Please go ahead.
Thank you, Daniela. Good day, everyone. As you can see on the screen, my name is Maxwell Majauta from Zimbabwe, under Family AIDS Caring Trust. I work for Family AIDS Caring Trust. So today I'm going to give you more of a straight case presentation of a child whom we managed at our clinic. So the background of our clinic is such that, yes, it is an OI, opportunistic infection, ART clinic. But currently we are seeing more of adult patients. We have our public sector who are doing more of pediatric ART initiations. So we have very few clients of pediatric patients in our cohort. So you'd find that this is going to be more of a straight case because we tried our best to try and see if we had any client who is a pediatric or an adolescent client whom we faced difficulties in trying to manage that client, but we decided that maybe we can present this one because we couldn't find anyone with difficulties who was more interesting than this one. So allow me to go through the presentations, and I think I have a few questions that I will ask at the end, then it will be open to the floor. Thank you. Okay, so these are the demographics. The initials of the client there, that's PM, who is now 8 years, but was 2 years of age at the at initiation, and is a male client. So next slide. So this is an only child. Both parents are alive and well. Both parents also tested HIV positive and were also commenced on ART. There's no family history of any chronic illnesses. Next slide. So the child was tested on the 15th of June in 2015 when the child was 2 years, and the test was HIV was positive, and the child was seen by our clinic nurse. The child presented with nasal congestion, but all other systems were okay. On examination, he was stable. The child was weighing 10 kgs and was on a full balanced diet. Next slide. Okay, so a systems examination was done. No abnormalities were detected. And as for the impression, WHO stage 1, laboratory tests, samples were collected as baselines, and cotrimoxazole was given as prophylaxis. That's the dosage there, 480 milligrams orally once daily for 2 weeks. And pre-ART counseling was done for the mother, and they were told to be reviewed, to be reviewed in 2 weeks' time. Sorry, it should be 2 weeks there. That's a typing error. So the client was also seen on the 17th. So it's 2 days, sorry. They were seen on the 15th because the doctor, I think, was not there. But here we usually initiate a client, then if the doctor is there, we review them after 2 weeks. So this was 2 days. So the client was seen on the 17th and 19th of June by the nurses again, and pre-ART counseling sections continued. But the nurses noted a low hemoglobin level of 8.5 grams per deciliter, which was suggestive of something. I think it will come in the next slide. Then the nurse ordered that client that they should be seen by the doctor for ART initiation on the 26th of June. Then client was seen by the doctor on the 26th of June. The weight was still the same. Systems examinations was normal. The CD4 count of 817, white blood cell count of 10.2, hemoglobin level, I think those were the same results. Platelet count 920, I think this was raised, as well as creatinine clearance, which was 104.29. Next slide. So the doctor gave an impression of anemia, and I think, yeah, this was a presumptive diagnosis, but also is suggestive of the hemoglobin level that was a bit low. WHO stage 1 is a diagnosis as well. So the doctor ordered to start the child on ART and was given AZT 3TC for 2 weeks, lopinovir, ratinovir, 100 milligrams and 25 milligrams for 2 weeks again, and to continue with cotrimoxazole or prophylaxis that was initially prescribed. Next slide. So on subsequent visits, the child showed quite a number of signs of improvement on ART with a progressive weight gain. The child is currently in primary school in grade 3. ART doses were adjusted appropriately when the child reached a certain weight band. So no opportunistic infections were noted during the course of the treatment, and the viral load remained suppressed as it was being monitored. Next slide. So this is a typical example of the adjustment of the doses that were done. For example, as you can see on the 25th, the weight was 15 kg, so 2.5 of ABC3TC was administered with Alluvia 125. But on the 30th of January, that was 2 years down the line, weighing 20 kgs, the doses were also adjusted accordingly, as you can see. Next slide. So a typical example also of the viral load monitoring for this client, with those dates there, like I mentioned earlier on, that the child was suppressed throughout the continuum of care up to today. Only on 30th of January this year, when the viral load actually raised from 0 to 80, but is still suppressed, is within normal ranges. So the child is doing well. So this marks the end of my presentation, which I alluded earlier on to say that it's a straight case, but we do have some questions that we might need to pose to our specialists. So the first one is, did we do justice to the management of the client? The second one, what could we have done better for the better management of this client? Then are there any other options for formulations, pediatric formulations that we could have used if they were available in the management of this patient? Thank you very much. I think this brings me to the end of this presentation. Over to you, Daniela.
Great, thank you so much. I mean, that was very relevant. And I know you're saying it was a straight case, but we are very excited to hear the responses to it. So thank you, Maxwell. So I'm handing over to Dr. Gambo. I'm just going to make sure that you can unmute. There we go. And yeah, we're very keen to hear your thoughts, particularly around Maxwell's questions on the slide. Go ahead, Dr. Gambo.
Hello, everyone. Am I on? Am I being heard?
Perfectly.
Thank you, Daniela. My name is Mahmoud Gambo. I work with Aminu Kano Teaching Hospital in Nigeria as a pediatrician, and I see pediatric HIV-infected children. I'm a member of the PATA family since 2011. I have been attending PATA activities physically and now online. I'm happy to be here for this engagement and expert review of cases. I want to first of all thank Maxwell for lucid presentation of his case. An 8-year-old male that was first seen at the age of 2 years and was diagnosed at that age with HIV infection stage 1. First of all, we would like to know whether the parents of this child have undergone PMTCT. If that was done, then we should probably have to review what went wrong. I know that it is not absolute protection to say that any mother who undergo PMTCT must have her child protected. There's usually a window of 1 to 2% failure rate. So could this child have been one of those 1 to 2% of cases of failure of PMTCT? If that is so, what drugs were used during PMTCT in the mother? Are they the usual, was she on dual therapy or was she on option B plus triple therapy? And is the mother on live treatment with ART, and what formulations was, or rather is she using? What are the events around delivery? Because we know that that is the time when transmission risk is higher as far as PMTCT preventions are concerned. So those are things to really look at in reviewing this case and find out, does this child already have an inbuilt resistance, or rather inborn resistance, that is transmitted from the mother that is not yet recognized? We have seen the series of viral loads that are suppressed for the first, second, and third testing. A count of about 8 cells per microliter. I think is nothing to worry about. That might really probably be a belief. And the only way to know that is to repeat that viral load in due course and see if it keeps on rising. And if it rises, has it risen to the level that we are to worry about? And coming back to the initiation of ART in this child, the question of whether justice was done in the management of this child, I think, Maxwell, I would say yes, you've done justice. Only that we should have looked critically at the level of hemoglobin of 8.5 grams per DL. That is actually severe anemia according to the standard WHO classification. And with that, one should have tried to sideline or remove zidovudine from the option and replace it with maybe another nucleoside reverse transcriptase inhibitor, probably abacavir, or any other option together with lamivudine, and then the nevirapine that the child, or rather the alluvia that the child was on. Because we all know that zidovudine suppresses bone marrow, it causes myelosuppression, and vis-a-vis the effects of HIV in a newly diagnosed ART-naive individual, one would have actually excluded zidovudine from the initial treatment regimen. Even though there are no other opportunistic infections recognized in the follow-up process, one would have to also look at the possible etiology of the anemia. Anemia of 8.5 grams per DL is severe, like I said. The child is lucky not to have manifested signs of anemic heart failure, and therefore, if that had happened, one would have experienced a lot of other complications from the anemia. So both the fact that cotrimoxazole prophylaxis was continued, that is okay, but truly that is one way to look at the aspect of the hemoglobin. Platelets seems to have been raised also, and we know that HIV, the virus affects basically all the hematopoietic cell lines, and thrombocytes are not spared by the virus and also by the drugs that the child could be taking. So could this child be having a form of thrombocytosis resulting from some form of stimulation? That we also need to know before the child begins to develop some coagulation abnormalities. So that platelets count of 920 cells per millimeter cube actually needs to also be revisited. I don't know whether a repeat test for that was done from the flu block count. We can see that. The fact that the WBC count, white blood cell count, is 10.2, that seemed to be within a normal range, and the white cell count seems to have been spared in this aspect. So, in my opinion, one would have tried to really find reasons to correct the anemia. This is a level of anemia that requires blood transfusion. And I could not see anywhere here that transfusion was done, or hematinics were given, or efforts being made to find other causes of anemia, bacterial infections that are common, even though that would have reflected on the white cell count, but not in all cases. Helminthic infections are common here in Nigeria, and when we see children with anemia of this severity, we try to look out for helminthic infections and treat it pari passu, so that one would actually have the identity of what is causing the low hemoglobin. In this case, this was not actually pursued to a large extent. As at the second visit, there was improvement. The child's weight keep on improving, but with the background of what I said earlier, then we need to probably do some more investigations in terms of his serum proteins, kidney functions, and see. Now that the child is 8 years, we can actually change to a better combination therapy. If the renal function is okay, we can choose TDF with lamivudine, and probably even dolutegravir as a first-line option. Like I mentioned earlier, these are some of my observations. I'm sure the members, participants, and the other colleagues here will probably have one or two things to say. I'll be available to answer one or two questions. Thank you very much, Daniela.
Hello. Okay, great. So thank you so much. That was very comprehensive feedback. And yes, it's really important to hear those thoughts, particularly around anemia. And I'm very interested to know from Maxwell whether this is something that he is feeling familiar with, or if it's something that he would like more input on. So Maxwell, can I go back to you? And I guess my question to you really is there anything that still feels unresolved for you on this case? Or are there any follow-up questions that you want to ask Dr. Mahmood before we ask Nandita and Pascal to weigh in?
Thank you, Daniela. I think that was very clear. Maybe just to say, when the client presented to us, in terms of PMTCT, nothing was done. They didn't go through the PMTCT management. So I think that's why the child also tested positive, like what the parents did. Then, yeah, the other comments, yes, I was listening. So I could have skipped one of the slides that was talking about the anemia, where some hemogenics were given, but it's such a long period. Maybe I could have missed that one when I was looking at the management of the clients, looking at the visits. I could have missed that, but I think something was done. If not, then I think, yes, going forward, I think we need to look at this seriously, because yes, it could have been missed, but I think something was done there. It's me. I think I could have missed it when I was preparing the presentation. So thank you very much for the feedback.
Great, thank you. I mean, yes, and also just to acknowledge, that when we look at a case in hindsight, and we're looking at the slides, and we've all got time. It's very different from when you're in the clinic and you've got a long line of patients waiting to see you, and of course things do get missed, but I think it's really important to have these opportunities to reflect, so that when we go forward, these are things to bear in mind. So brilliant. I want to just turn over to Dr. Sugandhi and Dr. Atanga, just to really ask you what stood out for you about this case. Just kind of a couple of thoughts, and then we're going to move on to the next case. So, Dr. Sugandhi, would you like to go first?
Sure. Thank you, Daniela, and thank you to you for inviting me to join in for this. And I think this was an excellent case. And Maxwell, I have to say, what stood out for me the most is this is, for all intents and purposes, a very successful case. This is a child who was initiated at 2 years of age on the appropriate regimen, using lopinavir ritonavir, and has been virally suppressed for many years and doing well, living with his parents. I think some of the issues, the points that Dr. Gambo had raised around the detail, looking into the details of the history, particularly the issue of anemia, I think also raises for us that there are multiple details in a patient's history that we need to remember, and that kind of documentation of what was done, what was followed up, how things were managed, is also very important when we reflect back on these cases. And I think that, he covered sort of the details of that history and the considerations around the differential diagnosis of anemia in a child such as this, whether it is from HIV disease itself, whether it is from a nutritional issue or from helminthosis. So there are multiple causes that I think could have been investigated over time, but here we're really focused on the HIV issues. But I also have to say, Maxwell, what really stood out to me is the questions that you asked. And And again, I'll say that from our HIV history, it's a successful case in that this is a child who's clearly been doing well on his treatment for several years. And one thing that I think really stood out to me is your question of did we do justice to the management of this child? And from a clinical standpoint, I think absolutely. This child's been on the correct regimens, on the appropriate dosing, and has had viral suppression for many years. And your question of could we have done better is a good one, because I think we always want to do better for our patients. And we're not, I think for many of us, we're just not at peace if it's just a lab result that's there. We really want our patient to thrive and remain healthy. A few questions that came to mind. Number one, your last question was about, were there better formulations? And I think Dr. Gambo also addressed this just now, that there are now, that he weighs 20 kilos, other options for this child, including dolutegravir 50 milligrams, which is now approved for use in children down to 20 kilos. And we will soon have new formulations of dolutegravir for those that are younger. And so that's one option for this child now. But I also wanted to point out that on lopinavir ritonavir tablets, which really has been what we've used for children less than 20 kilos, and what we still have is the lopinavir ritonavir formulations, is that those lopinavir ritonavir tablets must be swallowed whole. And I think that one of the things that really frequently comes up is that even though we may not ask this in so much detail, that very often caregivers will crush tablets or break tablets, and they're very used to doing that for multiple medications. But with lopinavir ritonavir formulations, this in particular, the tablets, these cannot be crushed or dissolved, or otherwise they lose their effect. And so that's one question I think I would also have gone back to. And oftentimes this is not the type of detail that's typically recorded in charts, but it's an important piece of the history of whether this child was on the right formulation and could swallow tablets whole. Though that said, I will say that over time, his viral load remains suppressed until this last viral load that was shared, which was a blip. And again, this was not a high viral load that he had, but it's also enough that we want to make sure that it's not on its way up. And a few things that occur to me here is, as this child gets older and he's taking, his dosing has been increased, his pill burden has also increased. And that may be one reason why he may have difficulty. I think any child would have difficulty taking so many tablets. So that may be one thing to explore. And again, the benefits of now thinking about better formulations or better drugs, now that they're available, could really help with his adherence if pill burden has become an issue. And the last thing that I want to bring up is the fact that this child has gone from age 2 to age 8 and sounds like he is doing well. But one psychosocial question to ask is, has he been disclosed to? So he's living with his parents. His parents are also taking ARVs. And as children get older, they become much more aware of what's happening around them. And an important question to think about is, has this child been disclosed to? Does he know his status? And have we discussed with his caregivers or with his parents how we're going to start the disclosure process? And so I think that this is a great case where, again, it looks like this child has been doing well. And from what we typically measure and look at a program level, this child has been managed very well. But I love the question of how could we do better? How could we think more in detail about what comes across as a pretty straightforward case, but how could we do better and do justice by this child? So I really appreciate, Maxwell, you sharing the case, and happy to hear more of your comments or questions.
Great. Thank you so much. I mean, that was just a very encouraging and affirming response. And Maxwell, it sounds like the feedback that you're getting is that you did a fantastic job. And of course, there are always things for us to learn. And I have asked Dr. Atanga whether he will kindly allow us to move on to the next case, which he's agreed to do in the interest of time. So we are going to hand over to Naluka. If one of the Pata team can help me just to unmute Pride. There we go. Great. And Naluka is going to take us through another case, and Dr. Atanga is going to lead on the responses to this case. So, Naluka, if you can hear me, you're welcome to go ahead.
First and foremost, I'd like to thank Daniela and the PATA team for this opportunity to make my presentation. Chipoka Rural Health Post is run by nurses. We don't have any clinicians and no lab technologists. So I'm going to make a presentation on a certain adolescent that had a high viral load. I have the next slide, please. Okay. Chipoka Rural Health Post is a clinic that is found in Zambia, Lusaka province, in Katuwe district. It has a catchment population of 3,665 people. The main activities that are conducted are maternal child health, ART, antenatal care, postnatal care, outpatient department. We have the TB clinic and adolescent health services. Next slide. We have a case of an adolescent who has access to Chipoka Rural Health Post for her medication. She was diagnosed with HIV on the 29th of November 2016, and she started her treatment on the 20th of December in the same year. Her first regimen was tenofovir, lamivudine, and efavirenz combination. Then in November 2019, her viral load was very high. It was about 5,221,365 copies per mil, which was too high. She was put on enhanced adherence counseling, but despite the enhanced adherence counseling, the viral load kept on increasing. Next slide, please. So we called one of her relatives and involved her in the care of this adolescent. And despite the relative helping out the adolescent to take her medication, there was no improvement. So the next time we did the viral load, it had increased from 500,000 to 600,000. And her CD4 dropped from 188 cells per microliter to 4 cells per microliter. We did not know what to do. And since we had no clinician at the clinic to support us, so we were stuck on what to do, because she was just taking her medication very well and sticking to her clinical appointments, but the viral load kept on increasing. Her family was also supportive to her, but there was no improvement. Then in October 2020, a team from the provincial health office came for a clinic supportive visit, and we shared with them the story of this adolescent. Next slide, please. Then they advised us to switch her to a second line of treatment, and they say that this adolescent has treatment failure. So we switched the adolescent to a combination of zidovudine, lamivudine, clopidogrel boosted with ritonavir. Then 3 months later, after the change of her regimen, her weight started increasing. It increased from 35 kgs to 43 kgs, and the viral load dropped to 38 copies per mil. Next slide. So this is what happened to this adolescent. Then the questions that we have is that was this the correct treatment for her, the one we switched her to? And why did she have treatment failure when she was adhering very well to her treatment? And the other question is that at what point of care should we consider switching a person to the second line or third line of treatment? Thank you very much. Over to you, Daniela.
Thank you so much, Naluka. I'm sure Daniela is reconnecting shortly, but thank you so much for presenting your case. Indeed, a very, very difficult case to manage, and would be really interesting to hear from our experts in terms of how they would, all the questions that you raise. So for your questions, we are directing your questions to Dr. Gambo, I think, is that right? Dr. Atanga, sorry, Dr. Atanga, thank you. Over to you, Dr. Atanga.
Yeah, once more, thank you for handing over the mic to me. And I want to use this opportunity to actually thank Naluka for her case presented from a Royal Health Post. I think that was quite an interesting case that Ms. Naluka presented. What was really, caught my attention initially was, the Royal Health Post that was providing both HIV and TB treatment. I think this is extremely not common in most of African settings, and you hardly really see ARVs and TB treatment being provided at this level of care. So that was really, really exceptional, and I'm sure that's why they could do what they could do depending on the platform that was also available at that level. So we really thank her and her team for what they did to this adolescent girl. I think I will start by just raising some questions that some issues that might have been much clearer. I think it would have been very interesting to have a bit more background about the adolescent. And I'm talking about, we don't know exactly her age at which she came into the clinic. We don't know her level of education, whether she was schooling or not. We might have also loved to know what type of support she had at the time she was about to initiate treatment, because these are some of the factors that will actually play on an adolescent. In HIV care today and in pediatric care in particular, the adolescents are quite a very peculiar group. And it's very, very important that at the moment you get an adolescent and initiating on treatment, you need to really have ample information that is going to support adherence to treatment, because they are those who can easily not adhere properly to their treatment. I think the team they did quite a great job. The treatment you started your adolescent on, I don't know exactly her age, but I'm sure, she could have been of age to receive TLE, and I think that was the right treatment for that moment. And you did well to start her on the TLE. First of all, it's a single dose, and so that should also have been very, very helpful. But one of the things that you really need to also note is that we look at your case. One of the challenges that we see there is we don't see exactly how the treatment was monitored from the very beginning, because your client started treatment, and the very first in 2016. But the first viral load that we see, which showed us that it was a high viral load, actually came up in 2019. So I don't know whether you had an opportunity to do other viral loads if she was really suppressed before then. If she was, then we might not be really asking questions, what would have happened in between? But I think in between 2016 and 2019, several things might have happened that might have also affected adherence on this treatment. But I think from the way you indicate in the case, she really did not have a lot of adherence problems. But again, we need to ask ourselves, what are some of the possible causes of treatment failure in the patients like this? I think we need to look at it from several perspectives. And generally, we have about 5 main dimensions in which the patients can actually develop treatment failure. The first, you have patient-related factors. And with patient-related factors, poor adherence comes in very, very fast. Even though you might have an adolescent in front of you and you're convinced that they are taking treatment, if you don't really have a treatment buddy, you might not be very, very sure. We've had some of these adolescents, she can be very regular at clinic visits, pick up all her medications, but then you are not very sure if she's swallowing the medications. So you might not know what is happening. There could be other problems related to the patient. You don't know, we need to know whether she had any other issues that could have affected, might be the pharmacodynamics or pharmacokinetics of her drug. Had she ever had some diarrhea and other these things, her weight was dropping and all of that. It might be at one moment she might have been taking her drugs, but due to a diarrhea or some other thing, she was not absorbing properly, or she was not getting adequate the optimal doses for suppression. That could also be a problem. There could be a problem of intolerance. There could be problems of inconvenience dosing, because efavirenz in that treatment could actually be one of the reasons why some patients will take it and they might not really tolerate it properly. So those are patient-related factors. You could also look at programmatic factors, because when you look at, we could also have insecure supply systems. Are we sure throughout this period she had all her supplies? That could be issues that we need to look at. They look at drug-related factors. Were there any other treatment that this patient ever had that could have contributed in, in drug interactions? These are some of the things that could play on the level of ARVs in the blood, and so the patient might be having suboptimal therapeutic levels due to drug-drug interactions. And then we have viral-related factors. And this is one of the things that we might not be I'm not very sure this could be the case with your case, that is pre-treatment resistance. I think there are quite a lot of reviews from WHO and other in-country studies where pre-drug resistance in most of East and Southern African countries with known reverse transcriptase inhibitors were estimated at above 10%. So at the time you're initiating some patients on treatment, you have quite a good number who might already be resistant. And if that is the case, I think your adolescent might not have been able to be on treatment for more than 3 years before actually developing treatment failure. But we don't know exactly when she developed treatment failure. But that is another possibility that you could actually have a patient who already had a drug resistance. However, we also have community-related factors. This is an adolescent. I don't know if she was going to school or not, if she was schooling. I don't know the relationship that she had with her schoolmates. Was she a boarding student? Is she a day student? And how could these are community factors that can actually affect the level of adherence. So we're not very, very sure how this might have affected your patient's adherence, but we think that those are some of the things that you really need to look into carefully to be very, very sure what could be the cause of treatment failure in this patient. So considering your last question, I think you did a very great job actually switching the patient at the right time and using the right procedure, because you had 2 consecutive high viral loads in between which you provided adequate adherence support And that was even shown by the fact that you even brought in a relative to support, and then your patient continued to have high viral load. I think that is actually the criteria that you need to use to switch lines. So that patient had 2 consecutive high viral loads, in between which you provided adequate adherence support, and yet, you know, they didn't suppress, she didn't suppress. So you went ahead to move her to second line. But from every indication, the way she responded to the second line treatment actually indicated that, you know, she might not have really have big issues with adherence, and she actually did well on the second line treatment. And we hope that you should continue that same support that you provided her. She might likely do better with her second line. I think those are my inputs that I had on Naluka's case. Maybe I will hand the floor back to Daniela to leave the other experts on the panel to bring their opinion. Thank you, and over, Daniela.
Brilliant. Thank you so much, Dr. Atanga. I think what was really so helpful is that not only did you respond to the specific case, but you also gave a structure for providers to think about when they're thinking about treatment failure, and within each of those buckets, provider related, patient related, etc. So thank you, that was fantastic. I'm actually going with Dr. Sugandi and Dr. Gambu's permission. I'm going to move on to the third and final case. And the reason that I think we should do that is because it is a particularly complex case. And I just want to make sure that we have enough time to go into it. And also, I really, really hope that we're going to have time to go into some questions afterwards. For those of you that can stay on a little bit after the time is ended, we'll keep the call open as long as people can stay. Okay, so we're going to move on now. And Futi, I can see your videos on, and I'm gonna just I don't seem to be able to unmute you, so maybe somebody else from the PATA team can. Somebody unmute Futi. Futi, are you able to unmute yourself? And just in the meantime, while we are just getting that sound sorted out, I'm gonna just move to Dr. Gambu, because I think Nandita's gonna give us your thoughts on the third case. But Dr. Gambu, I suppose I wanted to ask, and this is a very tricky thing to ask you to do, but at this moment, having been on the call now for an hour, is there a summary that you can give, a top line summary that you can give somebody who's just joined the call? You can just recap, I don't know, the 1 or 2 principles that we've heard.
Thank you, Daniela. I think I would like to just say that for the newcomers, this is a very, very important learning platform as far as HIV medicine in pediatrics is concerned. Here, we are likely to learn the best and to provide the best for our children in our various centers and hospitals as we work to support HIV-infected children. The process and the cases you can see are well selected. They are actually diverse and very, very good learning points that are raised. The type of experts that are selected, I can see they are very pertinent and gives what is required for participants to take home and improve the practice of pediatric HIV medicine. The last case, 2 cases are example of what is happening. And the third case that is also coming is a very rare case of adverse reaction due to kindness in pregnancy, hoping to see and learn from it also. So we can see that we are also here to learn, not that we are here to teach or to tell people or remind people what they don't know. All of us are learning, so it's a very good platform for getting together to know ourselves as part of family and to learn more for our children. Thank you very much.
Thank you so much, Dr. Gabu, and I appreciate your graciousness in saying that. That yes, in some areas, some people are experts, in other areas, others are. So there is opportunity for everybody to learn. Thank you. Okay, so I can see that Futi is on. Futi, can I just check that your sound is working? It looks like it is. Futi, can you hear us?
Yeah, it's better now.
So we're just having a moment of technical issues. I can see that somebody's there to support Futi to unmute. Maybe what we should do, just given the time, is that we should start to go through Futi's slides. And I'm happy to take a stab at sort of just speaking to some of the issues that Futi was going to raise, and then we'll really spend much more time giving feedback around the case, and not necessarily the presentation of the case itself. So, Angelita, if you controlling the slides, can you move on to the next one? Okay, great. So, I mean, essentially, Futi was going to speak about an adolescent as well. And I'm really going to race through this, in part because I don't know it so well, but also so that we've got time for discussion. So essentially, this is a case of a 15-year-old. She came, this was last year, she came into the ER, and she was really in distress, severe abdominal pain, vomiting, loss of strength, loss of appetite. And this was about a week's worth of symptoms. She was a known HIV positive case. She was diagnosed the year before, and she'd been initiated on ART then. So by the time she came into the ER, she'd been on ART for about 6 months. And the regimen she was on was TDF, 3TC, and nevirapine. Okay, we can move forward to the next slide. Okay, so essentially, and I think this might have been from the previous slide, but she was coming for her initial antenatal visit. So this were, I'm not sure if this was part of the emergency room visit or that was prior to it. But yeah, she's pregnant. She's come in distress, and she was known. She had no previous history of TB. She'd been screening negative until then, but she had epilepsy. She was a known epilepsy case, and since childhood. Okay, and then at her third antenatal visit, which was just before she came to the ER, so remembering this was probably about 2 weeks before she was initiated on IPT, and she's given 2 months supply. Okay, we can skip the next part. Let's go to the next slide. And then what I'm going to do now is I'm actually going to hand over to Nandita, because I don't think that this is important for us to go through. I think in a way, and Nandita, you can tell me if you agree with me, but we may be able to stop there with the case, and your conclusions and findings might already be relevant, given what we've gone through in the presentation.
Sure.
So Nandita, if you want to take over.
Of course, thank you, Daniela, and Futi, thank you for a complicated case. I think, Daniela, you mentioned that we've saved the most complicated case for last, though I would say, even though the first two seemed relatively straightforward, I think through our discussions and our experience, we can note that very few pediatric or adolescent cases are so simple. I think there are always complications, there are always details that we want to do better in managing. I do think this case was very interesting. I think, Futi, the the way it was put together, I think the clear issue here is the issue of hepatotoxicity, and I think that question of whether it was caused by INH, TPT, or from other drugs that this young woman was taking. Again, this is an adolescent, again, who often present us with very challenging cases. I think the word that Dr. Atanga used was peculiar, and I think that is an excellent word to describe many times when we're managing adolescents. And so what it seems happened here is that this was a young woman who was pregnant and who was also an epileptic, so already taking anti-epilepsy medicine. So she was taking carbamazepine, and she had been started once diagnosed in her first trimester on tenofovir 3-TC and nevirapine. And I think the objective assessment here shows that she's coming in with jaundice, with respiratory distress, with confusion, and very clearly has hepatitis or hepatotoxicity. But Danielle, I think, would you think you could go to the next slide? And so again, I think the differential diagnosis here is important to think through, is what are the things that could have been causing her symptoms. And there are a variety of things, though I think we were moving towards the diagnosis of drug-induced hepatitis. There are things, I think this is also very helpful to not forget that there are other reasons for the way she was presenting, and we cannot forget to review all those causes. Daniela, could you go to the next slide? And I'm not sure, Futi, if you're able to join in again, or if I should continue. I'm not sure if she's able to hear me, but I'll go through, and again, the treatment plan. Oh, she can hear me, but we can't hear her. So the treatment plan that was put together, again, given the risk of drug-induced hepatotoxicity, all medications were stopped. And again, if you look back at the lab values at her presentation, she was in a severe condition, and with some adverse events, you may be able to get by, but in a severe case like this, what you want to do first and foremost is stop all medications that may be causing the harm, as well as providing the supportive care that's needed. If you could go to the next slide, Daniela. Okay, I'm just going to, I think we don't necessarily need to go through this detail, though the slides will be available for everyone to review. But in going through, you can see here that really she was having, in particular, very high elevations of her liver enzymes. Her total bilirubin levels were also increased, and it really indicates that there is liver injury, significant liver injury here. But one thing also that's interesting to note is that her CD4 count was 92, and I think had dropped lower at one point, and her viral load was lower than detectable. So whether that was, hopefully that meant that she was taking her medications and doing well. But I think this is also where it becomes important to think through the history. First and foremost, if we're looking at this as the most serious issue here being toxicity, hepatotoxicity from the drug she's taking, it's important to review the drug she's taking. So we know that, again, in pregnant women, nevirapine itself has also been associated with hepatotoxicity. However, she also has a very low viral CD4 count, and we know that we used to see this more frequently in women with a higher CD4. But she was also taking carbamazepine, and that in itself can also be a risk factor. And then lastly, she was started on TPT, of INH prophylaxis. And currently our WHO guidelines and global guidance recommends that INH or TPT be provided to all people living with HIV, even pregnant women, though there has been some concern about the use of INH in pregnancy and the risk of hepatotoxicity. There have been some studies, some observational studies, and really at this point, there's not enough evidence to demonstrate that there is a clear association of TPT or INH with hepatotoxicity in more likely in pregnant women, but the concern is there. So again, I think it's an important point to raise that this is something that we should be considering. I think, Daniela, could you go to the next slide? Okay, so I think this continued to be the workup with follow-up over time, and including a workup and ultrasound results to look at her liver, her gallbladder, pancreas, spleen to make sure that see what was happening, blood transfusion to address the anemia and thrombocytopenia, as well as follow-up of her labs that showed improvement. And this, I think, is due to both the supportive care as well as the withdrawal of medications. Could you go to the next slide, Daniela? Okay, here, again, I'm just pointing out that in the second bullet point, she was reinitiated on her ART, as well as her anti-epileptic treatment of carbamazepine. And it's also interesting to note that IPT was deferred. And again, I think there has been concern when we see hepatotoxicity, and we consider that as IPT with pregnancy as a risk factor, and so that it was deferred in this case. Could we go to the next slide? And so the sort of lessons that came out from this case were that, again, this brings up the issue of polypharmacy, and that we think about our ARVs and our regimens quite frequently, but we also have to think about the other drugs that our patients are taking, whether it is TPT or isoniazid or other medications. In this case, she was also taking carbamazepine. And that is also, we know that is also a drug that interacts with nevirapine. And so one of the things that it is important to remember is that this may also have been a reason for some of the liver toxicities that could have contributed. In this case, when you look into the interactions between carbamazepine and nevirapine, it may lower the levels of nevirapine, and so it's likely that, again, these drug-drug interactions was impacting the effectiveness of her treatment. Though I will say the fact that she had a suppressed viral load is promising and is helpful, though again, it's something to be concerned about on an ongoing basis if she remained on this treatment. Lastly, I think there was also some mention here about thinking about alternative options. There are a few different types of apps, phone apps or online guidance to look at drug interactions. One that I use often is the University of Liverpool Drug Interaction Checker that provides very good guidance on which drugs interact with different ARVs. And it's one that I'll put the website in the chat box in a moment. But I think this speaks to the importance of making sure that the drugs that our patients are taking are not interacting. And so I think from this case, this is again an issue of how do we manage severe adverse events. It also speaks to the considerations around the risk of, or our risks of toxicity in pregnancy as well, and the issue of polypharmacy. A couple things that I also wanted to raise that sort of also speak back to our other cases. is the history here. And I think we're focusing very much on the hepatotoxicity and the drug interactions. We also have to think about the history that this was a young girl who was diagnosed at the age of 14, was pregnant at the age of 15 with a very low CD4 count. And that also tells me something. That also makes me wonder what the history of this young woman was. Was she someone who was diagnosed or was she somebody who was perinatally infected or more recently infected? And we know that there are many children out there that are yet undiagnosed and may present later in adolescence. We also know that there are many children who may have been identified early on, but dropped out of care, and then we may be seeing them again. And again, I think these are more historical details that we need to consider when it comes to the overall management of this patient. And I want to point out as well that this is a 15-year-old who's pregnant, and she was in care. And I do think that, again, we need to continue to stress the importance of sexual reproductive health services and access to that for all of our adolescents, even if they're coming in at a relatively young age. So I think this is a complicated case, and there's a lot to discuss here. But I think there's been a lot to discuss in every one of our cases. And so I'm going to sort of stop here and we can continue to discuss, but I'd love to hear thoughts from Dr. Atanga and Dr. Gambo as well regarding this one.
Dr. Atanga, did you want to chime in? And Dr. Gambo?
Yeah, yes, thank you very much. I think Nandita has given a very exhaustive review of that case. It's really a complex case, and I don't think I really have so much to add to what she has said, but I think the lessons in this case is so much around, multi-drugs, polypharmacy, and the possibilities of drug interactions. And I think one of the things that really stands out clearly here is, the use of anti-epileptics and ARVs, which I think is something that we really need to know much about. And the case here was carbamazepine, but there are other very common ones we use, phenytoin, phenobarbital, and these are all drugs that will not really do well with the common ARV regimens that we have, like what she was receiving, because these drugs, their potency will obviously be reduced, and at times you are expected to adjust the doses, but then it's not even recommended to have this to provide those combinations. So that's a really complex issue to handle. And then I also look at that the treatment she was having with nevirapine. We are in 20. That was in 2020, and surely again you look at issues around supply chain, and which is very, very challenging in most of our countries. That might not have been the most optimal regimen for her, but then I think that was available. That was what was available, and then she had to take it because already knowing that nevirapine is hepatotoxic, and then the patient was on nevirapine, and at the same time they had to receive INH with its own possibility of hepatotoxicity. I think that was already an issue. But what is really interesting in this case, which it's about having the viral load, which was quite suppressed. I mean, the CD4 was extremely low, and I was just wondering. And so I think that's a major lesson I'm learning from this case, that when we have patients with so many drugs, then we need to carefully review, and if possible, we need to consult colleagues to make sure that the decision on exactly what they should take should be should be properly streamlined, so that we don't get into drug interactions that might be toxic or might lead to suboptimal therapeutic levels of ARVs, which might not be very, very effective for the patient. So that was a little I just wanted to add. And then this is also an adolescent. I know we needed to also have more information on how she's really been followed up, what type of support she's getting, and how this could help her in the subsequent follow-up of her treatment and her pregnancy. So thank you, and over.
Thank you so much, Dr. Tanga. In the interest of time, I was going to ask the same question to Dr. Gambo, but in the interest of time, I'm going to ask you, Dr. Gambo, having heard a closing question to speak to our panelists and to our audience. Having heard what you heard today, what would you say to providers need to start doing, or to stop doing, or to continue doing? I mean, for me, what are the real key take-home lessons from what we've had today? Could you perhaps talk to us about what you think are the three top key take-home messages from all the cases that we've had today? Thank you.
Thank you very much, Agnes. I think learning from the cases that were presented today, we have far-reaching cases of very straightforward case and a complex case. And I think the learning point here will be to actually follow guidelines. Guidelines are meant for all of us to follow and adapt and utilize so that we do not err in our choice of treatment, in our evaluation of patients, in monitoring, in avoiding polypharmacy, and in avoiding drug-drug interactions and adverse reactions to drug like it's presented here. I think that is one thing to take home. The last case, I also want to say one word. If we still believe that this is a case of INH preventive therapy adverse reaction, might we be dealing with a case of slow acetylator? That is to say, someone who finds it difficult genetically to modify, or rather to metabolize the INH that she's taken. If there is a way that we can do that, then we will surely know, because then she takes INH regularly and she cannot metabolize it, and the level of INH increases in her plasma and causes a lot of damage in her liver, because the issue of carbamazepine and nevirapine actually were unlikely to cause the liver damage, because she has been on nevirapine for her epilepsy. At the introduction of nevirapine, which we might think could cause the liver damage, the level of nevirapine, like mentioned by Nandita, will actually be lowered. And in that case, it's unlikely to be the one, because the hepatotoxicity that we are seeing here extensively. The other things to really do comprehensive follow-up. Learning point number 2, comprehensive follow-up in difficult cases is very, very key. Here, we have to look at the area of the clotting profile. We are dealing with severe liver toxicity. We've done the liver function tests, which are deranged, but we have not seen an ultrasound scan done, and we've not seen the test of other hepatitis. For example, hepatitis C, which is very, very key pathogen when it comes to co-infection with HIV, and it can cause a lot of damage and fatality when it is not handled appropriately. So that could also be an angle, another angle to look at this case. But so to say, the treatments that were given were quite in very much good order. Thank you very much.
Thank you so much, Dr. Gambo. So much to take in and digest. Again, I'm conscious of time. I'm going to, before we close, I'm going to hand over to Dr. Sungadi to give us a few closing remarks, and Daniela as well, and then we'll close. But we are really, really indebted to how you've, sorry, go ahead, Dr. Gambo. Go ahead, were you trying to say something? Okay, I can see you're speaking, but you're on mute. So I'll carry on. Okay, so I'll hand over to my colleagues, Dr. Sugadi and Daniela Mark, to give us a couple of closing remarks. Thank you very much, everyone.
Thank you, Agnes, and again to my colleagues. These are great cases, and I think as Dr. Atanga was saying, that it's important to know what the guidelines are. We are also having changes now. We're seeing transitions to new regimens. I also wanted to point out, though, that even though we sometimes have the guidelines in front of us, I think as these cases demonstrated, when a patient comes to us, they don't come with a copy of guidelines in their hand, and they don't follow it line by line themselves. And so I think that's up to us to look at the patient as a whole. And I don't think there's any guideline that can take the place of a careful healthcare provider who wants to do justice by their patients. And so, you know, just for this last case, I'll just leave you with some thoughts for this last case in particular, is that when we see a case come to us, we have to think about immediately what's the problem in front of us, but also as if, you know, we had to manage this young woman's hepatotoxicity and acute state when she came to us. But we also have to think about the medium term and the longer term. And in pediatrics, this becomes very important because we know that these are children and adolescents that have a long life ahead of them if we do our jobs. And so we also have to think about the medium term, which would include things like managing her pregnancy, restarting her on ART, and then in the longer term as well. And so I think there's a way that we need to move through these cases that really reflect the real world and how we are seeing them on a day-to-day basis. And really, to Pata, thank you for bringing this together as an opportunity for all of us to learn.
Great, thank you so much. Yes, I mean, just to extend our deepest appreciation to Nandita, Mahmoud, and Pascal for your brilliant input, and really, you know, gave us so very much to think about. We want to thank Maxwell and Naluka, and we also want to thank Futi. And Futi had a second case of an 8-year-old that was just as fascinating. So we'd like to extend an invitation to Futi to present that case at the next reel, and we'll work together to make sure that the sound is fine. And yes, I mean, I think what Nandita's just said about you know, the commitment to you know, dealing with the patient, seeing the patient holistically, and really nothing can replace a health provider's interest and commitment to the patient in front of them. I mean, I've been watching the participant box. You know, by the time it got to the closing session time at 4:30 South African time, there were almost 100 people still on this call. And that, to me, is the greatest testimony of all of your commitment and dedication to your patients. There could be no higher commitment than joining a webinar, listening to other people's cases at the end of your very long workday. And we just salute you and we appreciate you, and we think the absolute world of you, all of you listening today. So you'll hear from us about the next real session, and thanks to everybody. We'll see you soon.
Paediatric AIDS treatment in Africa, man. To the bata. Them a big black man so proud, man.
Yeah, your people. Well, this song is dedicated to the children of Africa. We're here to say that no child should be born with HIV in Africa. And if you believe with me, rise on your feet and let's sing together. Yo, 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 yo.